Hi, everybody. It is Dr. Laura Hanson with Connect My Brain. So glad that you're tuning in today. We are in a new series that we started last week, and it's involving reviewing cases that have come into the office. And that way, perhaps it will help you identify an area that maybe your child is really struggling with. And sometimes even adults connect dots on themselves. So let's dive in so that we can get through all of the detail. So this was a little 10-year-old boy who came into the office, and the chief complaint was ADHD diagnosis as well as dyslexia. And there was a mild motor tic. Automatically, when I see motor tic, I'm thinking we need a strep antibody test. You know, about a decade ago, they thought that strep was associated with an autoimmune issue called pandas, and now they know for sure that it is, and you don't have to have a full-blown pediatric autoimmune disorder, but you can have some of the components of it. So strep is a really important one to find out if that number is way too high. And I will talk about the findings for this as we move along. But that is something that immediately when I see that in a history, I'm going to want to do a strep antibody test so I can see what that titer actually is. Their focus was that they wanted to improve, focus on the child, and resolve hyperactivity without medication. She had to be on complete bed rest during her pregnancy. That's always a red flag to me because babies have to move in the womb in order to make neural connections. So we always want to find out, why did we have to be on bed rest? Because it could change the complete outcome for the baby as far as development is concerned. Then the APGAR score was only 8 and then 9. So a perfect APGAR score is 10. So we're talking about a brand new baby. We're talking about it coming out of the womb. In fact, this one, though, was an emergency C-section. That always is a red flag for me. But when we don't get a perfect score, there's a reason why. So the APGAR score is going to grade for different components of the baby's health. And so if it's less than perfect, that has the possibility that something is going on for the baby. So my next red flag is that it was an emergency C-section. I keep hitting my microphone, and I hope that does not vibrate out there for everybody. Okay, my next red flag. The baby was in the NICU for 6 days after birth with oxygen because the oxygen levels were dropping every time the baby would go and suck. Now, sucking is a reflex. It's needed for survival, but we all know that mama's milk doesn't come in for a couple of days. And so this reflex is already there. So while the baby is sucking, it literally is dropping in oxygen. And I'm going to really spend some time today on the Moro reflex because it is related to oxygen. And that part is really important for all of us to understand how that reflex actually works. After discharging on the way home, he stopped breathing again, had to go back to the hospital for an additional 10 days. So that's a big red flag for any little baby to go through. Okay? All right. And then looking at the child's part, getting more into their earlier years, we had areas marked for clumsy, allergies, asthma, balance, and there was a comment about he was a really good sleeper. So I always want to know, what does that really mean? Because a lot of times people think if a baby sleeps really long, because it really gives us a break as mamas, that's a really good thing. But babies have a particular pattern in sleep that we need to monitor, especially as a newborn. You expect that baby to sleep about 2.5 to 3 hours. That glucose from being fed up in the brain is going to be utilized faster than any other area. So in the very beginning, our newborn babies wake up about every 2.5 to 3 hours. So if you ever notice that your baby is either sleeping longer than that or shorter than that, it might be part of a story that relates to any issue that can be going on for your child. Let's see. So let's go into some of the findings from the assessment and connect the dots. So what we did is we always do our brain map. It was very difficult for him to sit still. And many people think that children are really exercising a behavior of lack of cooperation if they're constantly moving around. So let me connect this dot. We have the potential of what I'm going to refer to as reticular sedation as an issue for this child. Okay, so what in the world is that? So we heard a lot about an emergency C-section, lack of movement during the pregnancy, and then oxygen issues at the time of birth, and went on for several days following the birth. So anybody that doesn't have enough oxygen is certainly not going to have a great deal of energy, right down to that baby. A lot of times what you really are seeing with a child that is constantly moving around, there can be an issue with, I'm doing this because I need help staying awake. I really don't know where I am in space, and if I move around, I get some mechanoreceptors firing in my body, and it helps me a little bit know where I am in space. So there's really some reasons why children can become quite fidgety. It could also be a primitive reflex like spinal gallant, where if they wiggle too much and move things on their back, they're actually going to urinate, because that reflex is associated with the birth process and eliminating the byproduct of pregnancy, and that's in the form of urine and the notorious first bowel movement that a child has at the birth process. So there's many reasons. And so just because you have a fidgety child, I can't tell you that it's just this one thing. There's many reasons that kids have to move around. And here's the other part. Maturity of movement is actually the ability to sit still. So there's so many components just to moving around. And the only way that we're going to know exactly what's going on for the individual is by doing an assessment. So we had a hard time getting that brain map because it wasn't easy for him to sit down. When we started looking at the coordination between the upper body and the lower body, there was lack of appropriate timing. So when we think about a baby coming into this world, it is in hard flexion. In fact, if you tried to move an arm, they would resist you. So the first thing they start doing is lifting their head. And everybody comments, oh, can you see they're lifting their head? Then the movement begins to get into the upper joints of the shoulder and the upper torso. Then it starts to get involved in the whole trunk and the distal arm or the rest of the arm. Then it goes into the pelvis. Then it goes into the proximal or upper legs and then down into the lower legs. So there's a different timing sequence that goes on between how the upper body comes online and how the lower body comes online. So it's important for us to look at that coordination between the upper body and the lower body because it starts to pinpoint a time frame. A time frame when perhaps greater interference was coming into this child's life. You know, it's like a set of dominoes. If I set up a pattern of dominoes and I hit that first one, the whole thing moves in a beautiful, smooth sequence. But if I were to take out one of the dominoes, it's going to stop. It's going to stop where that interruption in flow has occurred. But the thing that does continue to happen is adaptation. So there's 5 areas that you look at pediatric development: fine motor, gross motor, social communication, and adaptation. And these systems are marvelous for adaptation. However, it doesn't mean that adaptation doesn't come at a cost. So just because we have that category doesn't mean that it's always perfect. In fact, what I find with children is that they have to work so much harder at things. And you're probably going to hear me say this in every one of these podcasts within this series. Children do not have a point of reference to tell you that it's hard. They just do. In fact, when he did his little jumping jack movement, he jumped right into it, but it was only his upper body that was moving. His lower body was like on a pogo stick. So the upper body and the lower body were not moving together in the same rhythm, but he kept going. So he's trying. He really doesn't have a concept yet that that's not exactly the pattern that we're looking for. So that's the idea behind even just looking at timing. It was very difficult for him during the entire assessment to stay focused on what we were doing. In fact, I had to bring him back many times in order to get him to be present with the assessment that we were doing. And when children drift off, that's that theta brainwave that is just overpowering what feedback they're getting. So again, I'll talk about brainwaves quite a bit. Delta is your sleep wave. Theta is the precursor to sleep. It's also your imagination. It is your subconscious. It's your creativity. It's when these kids kind of drift off into a daydreamy state, they will kind of float away on that theta band. And these are the kids that are typically labeled some form of attention issue. And we're gonna really dive into that concept today in conjunction with the Moro reflex and oxygen. The great part was that he did lateralize correctly, which means that his eye, ear, hand, and foot were all dominant on one side. That's a very important marker because it gives us a peek into how well did the brain get organized. However, when I asked him to do a writing sample, and if you get to see this on YouTube on a video, you'll get to see the next picture. If not, I'm definitely going to describe it to you, but it will be up on the videos shortly. But what this is I'm asking him to write the alphabet all the way across the middle of the page so that there's no point of reference for him up here at the top of the page or the bottom of the page. That way I can truly see his ability to navigate a straight line when he writes, because I'm looking at how the eyes are coming together and the hand is coming together in order to print on a piece of paper. So when I fold this in half, it's going to give me a line right down the middle. And we have a lot more of the alphabet on the left side of the paper than we have on the right side of the paper, even though the instruction was all the way across. We're also trying to get that child's perception of when you get a direction, how do you follow it? So what that means is his eyes are not teaming together and he's having difficulty crossing the midline of the paper, but also after the midline, the whole right side of his environment has possible interference there. It could have to do with eye movements. It could have to do with primitive reflexes. Those are the things that have to be identified for each and every child, because they're doing what they think you're asking them to do, but this is their perception. This is their adaptation. So that's another part of trying to learn, where is this child in this part of the development. So also when we did the metronome, and I talked about the metronome last time, but you may be just kind of joining in. The metronome is a timing therapy. So you first start with both hands clapping. The lower the score, the better, because it means that you're able to clap with the sound. You're accurate with a lower number. And you literally can go all over the body with this particular therapy, as well as we get very creative in the office with what we do with the interactive metronome. His scores started off both hands 121. So when he started, it wasn't bad. It's close to 100. But as we got into the cross crawl pattern, so left hand, right foot, 236, right hand, left foot, 234. So that's more than double. Balance on the right foot was 301. Balance on the left foot was 280. Then both hands with guide sounds, meaning that if you're a little fast or a little slow, you get a slightly different tone. That number was 98. So that really raised a little antenna for me, because he's already finding strategies in his environment that are helping him perform a task. So he found the guide sounds helpful. Some of the children don't find the guide sounds helpful. They get irritated. So then when we looked at sound, we had sound lateralized at a low frequency and a medium middle frequency to the left ear. So there's still some skewedness there. High frequencies were equal, but the air conduction was shorter than the bone conduction. So sound assessment is looking at how well did these ears develop? Because when you come into this world, you first perceive low frequency sound. You have to acquire middle and high. Now, this is not the most subjective test on the planet, because I'm only looking at 3 different frequencies. However, there's a low, a middle, and a high. And I can at least get a peek into how this child is hearing. So I place a tuning fork right on the top of the head. It's vibrating. The sound's going to travel. You should be able to hear it equally in both ears. So with the low and the middle, it lateralized to his left ear. He heard it better in the air in his left ear as compared to the right. So that's creating an asymmetry for how sound is going into this individual. When I went to the high frequency, it was perceived equally, but when I went and timed bone conduction on behind the ear, and then air conduction on the outside of the ear. He could not hear it as long in the air as he could hear it on the bone. And you should hear it longer in the air. So it just raises another component. How well did this child get integrated? Well, the ear is going to mature by age 3. So again, what's starting to happen is I'm starting to get some markers that even though he did have a rough beginning, there's also another issue that started somewhere before the 3rd birthday and continued that played a significant part in how this child got developed. So the other part in the history, if you remember, we had allergies and asthma. So the immune system is going to mature by age 3. The belly is age 2. Balance coordination at the cerebellum level is age 4. So there's windows of development. So this is how I break down how this child got wired up with the information regarding their history, and that's how we can put it together so we know exactly what kind of a program to put together for this child. So as we move forward, the only other thing from the details, when we did the strep antibody test, he had a number of 206, and that's too high. If it's above 130, I start to have some caution, because what it means is there's still some strep lingering inside. And strep is a pretty smart bacteria. Most people handle strep with antibiotic. So if we get broad spectrum antibiotics, we're wiping out all the good guys. And strep mutate and move around very, very quickly. And before you know it, you may have already gotten through your protocol and there's still strep lingering around. So this is an issue for what connection I made with the motor tic. And one of the things that we do here, we handle high strep antibody with homeopaths. And if you're not familiar with homeopathy, that is medicine, but it's at a minute level, so there are no side effects. And we've gotten excellent results really clearing that strep. And we will do a follow-up strep antibody test to make sure that we cleaned it out. Okay, so now let's spend the rest of our time really diving in to Moro. I think this is probably the most important of the primitive reflexes. It is so important because it is the first one in line for primitive reflexes right after the withdrawal reflexes. And it starts 9 weeks in the womb. It activates 3 things in the neurology, which is arousal, CO2-O2 reflex, and the sympathetic nervous system. Now, what I want you to keep in mind with our case is that we have a emergency C-section baby, not just a planned C-section, but an emergency one. And then we have a baby that had to go to NICU because the oxygen was dropping every time he was sucking. And then even though they thought he had become stabilized, he wasn't and had to go back for another 10 days. In the big boy role, how does this stuff tie in? Well, remember what I was telling you about distraction. Another component to the assessment is literally looking at endurance. And so when we start with our endurance assessment, we get a pre-oxygen level. His kept fluctuating between 95 and 97. Ideal, you should be at 99. His heart rate also was fluctuating between 83 and 101. For a 10-year-old child, that's high. When he did his 3-minute test, that oxygen did go up to 99. So he does have the capacity to get oxygen going through his body, which is a real plus. And then his post pulse after that 3-minute was 129. And what was really interesting was that at the 5-minute test, his numbers were exactly like his 3-minute test, the 99 and 128 rather than 129. So when you have 5 minutes of an endurance test, your aerobic system should normalize. So it didn't come down. I should have seen it come down just a little. So there's an endurance issue. And again, if I don't have enough oxygen, I am going to have an endurance issue. Okay, so how does this tie in to Moro? Well, first let's understand what triggers a Moro. What triggers a Moro reflex is any sudden change in the environment. So it could be handling, it could be a sound, it could be a movement. That stimulation literally is going to impact the vestibular system. And if there's any change, any sudden change, even in light, that's going to change them or trigger the Moro, as well as pain or temperature. So we're talking about the vitals of the body. We're talking about the special senses of the body. And we're talking about pain is the one that's also associated with developing that withdrawal reflex. So we're really at the core of human life. And so any sudden change in just about anything can trigger a Moro response. Now, don't forget, Moro is normal. It's normal from 9 weeks in the womb until 4 months postnatal. But by 4 months postnatal, you should integrate that reflex and move on. But we've got some different triggers in this particular case. We have a mama that was at bed rest, so we could have a lack of neurological responses in that child. And based on the fact that he had to go to the NICU, and of course what I saw in the assessment, I don't think that child was adapting and transitioning to its own environment. So when that happens, it's Moro is very, very different when you're actually being born. So when you think about Moro, you think about this quick movement and breath. So if you're listening on the podcast, I'm starting with my arms flexed and simulating if I have a quick interference or stimulation in my environment, the head goes back, the arms and legs open up, there's a quick inhale, and then there's a very, very, very slow exhale, and the baby comes right back to flexion. Okay. Now remember, the arms don't move out so much, so it's not a big grand opening. It's just a little bit of these arms opening up. And I'm sure every mama that's ever had their newborn baby around them has seen that little twitchy kind of a look that Moro has. So it's important to know that when we're actually going through the birth process, Moro acts differently. So there is the arousal factor, there's the oxygen factor, and then there is the sympathetic nervous system or fight or flight. So at birth, this thing slows everything down so that the baby can move through the birth canal, transition through the birth canal slowly, and be able to not have to breathe heavily or move their bellies heavily, but literally using the rhythmic nature, the orchestra between mommy and baby in order to push and tootsie roll that baby out. So at this point, everything is slowed down. So we have an interruption at this point for this child because we have an emergency C-section. So there is no transition. There was a decision made and there was an incision made and the baby was removed and the cord is cut immediately. In an ideal situation, especially for a first-time mommy, you should have as much time as you need in order to bring that baby into this world. And lots of times it's a 24-hour experience. And then with multiple births, it gets shorter and shorter because now your body has practiced how to do this and your body knows what it's doing. So in this ideal situation, we have a smooth transition. Reflexes are able to complete their process and babies come out. And in an ideal situation, we don't cut the cords immediately because there is a lot of transition that needs to go on. You know, when a baby is inside of the womb, its oxygen is going from its right atrium to its left atrium in the heart. And the heart actually has 4 chambers, and it's bypassing that through a little hole called the foramen ovale. But at the time of birth, that's starting to close. And when a baby is brought into the world, it's laid on its right side and up close to mama's heart. So it's literally creating a pressure gradient while that hole is closing down. Meanwhile, the atrium is filling up, and then it's going to force the mitral valve open to go into the right ventricular. So, I mean, there's so much that's supposed to go on during this birth process. And when we schedule it, and please, there's no judgment. I had a C-section. I wish I had never had one, but I did. So it's not about judgment. It's about learning. And even if you're not going to have any more children, share it with another woman. You know, not many people are going around telling women how these things are actually supposed to happen. And we need to preserve our children. And every part of prior to conception, pregnancy, labor, delivery, the first few years of life, this is the most marvelous time for our babies. And this is what's going to ensure you that the health of your baby is there. So we've got a situation in this case where all those ideals were just not able to happen. And therefore, we've got a child now that has many developmental delays. And when you look at a history, you can't ignore that. That is the person's blueprint. Therefore, it all is part of the situation. Okay, so now let's talk a little bit more about Moro. So we know what triggers it. What happens? What's the physical response? There's an instantaneous arousal. There's a rapid inhalation, a momentary freeze or startle, followed by expiration and accompanied by a cry. There's activation of the fight or flight response, which automatically alerts the sympathetic nervous system and results in release of adrenaline and cortisol into the system. These are our stress hormones. Increase in the rate of breathing, particularly in the apices or the upper lobes of our lungs. Therefore, there could be hyperventilation. There is increased heart rate, rise in blood pressure, reddening of the skin, and a possible outburst. So those are physiological responses to the Moro reflex. So before I go over what are retained components of that Moro reflex, I just want to highlight the arousal piece, the CO2 piece, and the sympathetic nervous system. So arousal, in my opinion, this is associated with any kind of attention deficit label. So baby has to be aroused when it first gets here because that's how they get your attention. They cry, just like I was reading. They have a physiological response. I'm wet. I'm uncomfortable. I'm hungry. And we get a little bit of an outburst, right? So it gets our attention. Over time, beyond that 4 months mark, things are going to start to normalize, okay? But you can have a situation that impacts the moro to where we've got an under-aroused child or an over-aroused child. I want you to think of under-aroused as attention deficit and over-aroused as attention hyperactivity, okay? Now, arousal moves into what it's supposed to do with these reflexes is grow up, okay? So the first thing that a baby does is we pay attention to them. Our next transition, always using the same words, is to teach that baby how to start taking care of themselves appropriately. So the first thing that we're going to start doing is potty training as a toddler. And so we take the baby into the potty. We sit them down. They absolutely have no idea what we're doing. We might read a story as the baby relaxes and the pressure up against their little pelvis, they tinkle. We throw a party. The baby is paying attention to your facial expression and mimicking it in the ideal situation. So over time, practice, repetition, frequency, the baby starts to know, the toddler starts to know, I'm going in this room and I'm tinkling. Over time, the baby toddler is going to start to feel the little feeling that you feel right before you need to go to the bathroom. And as that child grows up, that child then can begin to execute taking themselves to the bathroom. Well, we have to be able to do things like this to be able then to go to school to pay attention to a teacher. If I have things that are beating down my nervous system, I'm not going to be able to pay attention. Oxygen. We already saw in this particular case what went on for this baby. And yes, it can be life-threatening. In fact, this has a very strong connection to SIDS. Because if I have an under-aroused moro reflex, it got interrupted, it didn't finish, and I'm not responding to things, then the CO2 is going to climb up in that baby. They won't startle, they won't take that deep breath, and the baby, unfortunately, will drift off into a deep sleep and passes. It is incredibly sad when this happens. And then the third part is the sympathetic nervous system. This is the beginning of the fight or flight response. So kids, babies can have fight or flight reactions in the body. In fact, there's been all kinds of different research and ultrasounds and video that show babies actually startling in the womb because there's a lot of stress going on around them. These are real things, and they literally play a huge impact in the development of the child. In fact, I will say with 27 years of experience, if a child had developmental delay, every single one of them had a retained moro reflex, meaning it did not integrate like it was supposed to. So as we're wrapping up this particular case, this is where I think this part will be incredibly profound for you to say to yourself, am I still going through this? Because it really does play a part about parents and their impact on their children, or just as an adult trying to function in life, but absolutely for your child. I really do focus a lot on children because they're in this state right now where their subconscious minds are being formed. They form from the time probably around last trimester of pregnancy to about 8 years old. I have an incredible opportunity to re-navigate that shift, and I feel honored and blessed to be called to do this kind of work. But there are many adults. In fact, when I did this training, I often referred to myself as a recovered Moro. I absolutely had a very heightened Moro reflex, and I'm very glad that today it is integrated. So I'm going to wrap up by reading this list. It's a little lengthy, so bear with me. So long-term effects of retained Moro reflex: vestibular problems such as motion sickness, poor balance, and coordination, particularly seen during ball games. Physical timidity, oculomotor eye movement, and visual perception problems can be very stimulus bound. Like when you drive, do you have to stay on the line? That's what stimulus bound means. Cannot ignore irrelevant visual material within a given visual field. So the eyes tend to be drawn to the perimeter of a shape, much to the detriment of the perception of internal features. Poor pupillary reaction to light, the little black dots in your eyes. Photosensitivity, difficulty with black print on white paper. The child tires easily under fluorescent lights. Possible auditory confusion resulting from hypersensitivity to specific sounds. The child may have poor auditory discrimination skills and have difficulty shutting out background noise. Allergies and lowered immunity. Asthma, eczema, or a history of frequent ear, nose, and throat infections. Do you remember that in our case today? Adverse reaction to drugs, poor stamina, dislike of change or surprise, poor adaptability, poorly developed CO2 reflex, reactive hypoglycemia. Lots of times they may experience anxiety, angst, excessive reaction to stimuli, mood swings, tense muscle tone, difficulty accepting criticism, hyperactivity followed by excessive fatigue, difficulty making decisions, weak ego, low self-esteem, insecurity, need to control or manipulate. Boy, that's quite a list, isn't it? Well, you can always go back and listen to it again, but there's pretty much everything about trying to adapt to your world in a way that will promote the best possible child is being squashed. So if you have anyone, especially your own child, and you're concerned, these podcasts are a way for me to reach out and help my community. And I think of my community around the world, and give some information about understanding how a child develops. It is so important to look at that developmental assessment and begin as early as possible to correct those things. My deepest heart passion is to create a team where we go into schools and we are assessing children before they start school, even as early as 3 years old. But you can see that there's actually markers that are there right after a baby is born. So as early as you can get this done, it's really going to make the journey so much easier. However, some of us don't find answers until later. So anytime the brain can change, as long as we're willing to roll up our sleeves and do the work can be done. Please feel free to reach out. The office number is 678-501-5172. You can go over to the website, connectmybrain.com, and there is a place where you can fill out a form and request a phone call. And I'm happy to get on the phone and talk to you about your little person. Thanks so much for joining today, and an extended gratitude or an extended statement of gratitude to my podcast manager, Marcy Page. She's really been putting up with me lately. I've been so busy, and trying to get my podcast done has really been a challenge, but she keeps me on track, and I'm forever grateful to that. So thank you, Marcy. I wish all of you a wonderful day, and get out in that sunshine, put your face in it, and feel happy and be blessed.